Hello everyone, I'm Dr. Ahmadzade from the Academy of Online Radiology Education and a research fellow in the Department of Radiology at Baylor College of Medicine. Today I'll be presenting 3 recent studies that highlight how artificial intelligence is being applied to glioblastoma segmentation and treatment response assessment. Glioblastoma or GBM is the most aggressive primary brain tumor, classified as WHO grade 4. Even with maximal therapy, the median survival is just 15 to 18 months and recurrence is common. That makes imaging follow-up essential. It guides tumor board decisions, helps detect early progression before symptoms worsen, and informs eligibility for clinical trials or second-line therapies. Currently, we rely on 2 standards. RANO, which uses bidimensional MRI measurements and clinical features, and BT-RADS, which provides a structured reporting. Both are helpful, but they are time-consuming, subjective, and vary between readers. Manual assessments also struggle with non-measurable lesions, pseudoprogression, and reproducibility. These limitations drive the search for automated solutions. Now, why AI? AI appeals to us because it promises efficiency and objectivity. Volumetric analysis may capture tumor burden better than 2-dimensional measures. Still, AI must be clinically meaningful, not just mathematically accurate. That means holding up across institutions, working in different populations, and integrating into routine radiology workflows. So far, evidence suggests AI can assist radiologists, but it's not yet ready to stand alone. The first study is by Suter et al., published in Frontiers in Radiology. The objective was to evaluate automated segmentation tools BT-RADS and HT-Glio-Auto for glioblastoma response compared with expert RANO assessments. This was a retrospective study of 80 patients with 502 MRIs. Automated 2-dimensional and volumetric measurements were compared against neuroradiologists, including analysis of time to progression and correlation with overall survival. They found agreement with experts of about 80% for HT-Glio and BT-RADS. BT-RADS matched expert time to progression most closely, while HT-Glio showed the strongest correlation with survival. But both tools struggled with lesion counts and non-measurable lesions. The implication is that AI segmentation shows promise, but it still requires expert supervision and broader validation before being ready for routine clinical use. The second study is by Zhang et al., published in AJNR in 2025. This was a large retrospective study of 634 patients with over 3,400 MRIs. The team developed AI BT-RADS, an automated volumetric tumor response tool aligned with BT-RADS. They used NN unit segmentation to generate volumetric scores and compared these with neuroradiologist assessments. They also tested its ability to stratify survival outcomes. The results showed moderate agreement with radiologists. However, survival prediction was weaker for AI, with a Cox model showing a statistically significant disadvantage compared to radiologist scoring. This demonstrates that AI is feasible at large scale, but it's not yet superior to expert radiologists. At present, AI works best as a decision support tool alongside human interpretation. To sum up, we included a systematic review as our third study. This systematic review is by Shi and colleagues, published in Neuro-Oncology in 2025. They systematically evaluated 20 machine learning studies on automated longitudinal treatment response spanning 2010 through 2024. Many studies included a reported strong technical performance, for example, dice coefficient above zero point 0.8 for tumor segmentation, but there were significant weaknesses. Very few prospective studies, limited external validation, and high risk of bias in patient selection and reference standards. Because of this heterogeneity, a meta-analysis was not possible. So the conclusion was that while AI is promising, it's not yet clinic ready. More prospective multi-institutional validation studies are urgently needed. When we put these three studies together, we see a clear pattern. Suter showed AI can approximate expert assessment, but still needs supervision. Zhang showed AI can scale across thousands of MRIs, but it's still not yet superior in predicting survival. And she showed that the overall literature is still immature. So AI brings efficiency and consistency, but human oversight remains essential. To conclude, AI is enhancing glioblastoma response assessment through automated volumetric tumor segmentation, faster and more consistent measurements, potential integration with RANO and BT-RADS frameworks, and support in survival prediction and monitoring. Glioblastoma patients have limited survival, making accurate, timely follow-up critical. Manual RNAO assessment are subjective and slow. AI can reduce variability, save time, and complement expert interpretation. So we need prospective multi-institutional validation, a standardized volumetric threshold for progression, and workflow integration. Training the next generation of radiologists to be AI literate is essential. The future is not radiologists versus algorithm. It's radiologists plus algorithm, working together for better patient care. Thanks for watching. Follow ACORE for updates on neuroradiology research.